Hello, I'm Adrienne Mishkin. I work in the CL Psychiatry Division at Columbia University Medical Center in New York, and I'm going to talk to you today about our project looking at barriers to workplace lactation success for psychiatrists and psychotherapists. We have nothing to disclose. I'm going to talk to you about what the medical recommendations are for lactation, a little bit about the context of gender inequity in medicine, what the prior studies show about barriers to lactation in physicians, and then I'm going to tell you about our study and what we've found so far. So, what does the WHO say about lactation? So, from 0 to 6 months, infants are supposed to consume human milk exclusively with nothing else in the mouth, no water, no pacifiers, and infants should be able to eat on demand. Anytime they're hungry, they should be able to have milk. Between 6 months and 2 years, we should be adding safe and adequate complementary foods while continuing to breastfeed for up to 2 years of age or beyond if desired. There are benefits for both the child and the mother. For children, especially in middle and low income countries, there's a reduced rate of infection, including reduced rates of infectious diarrhea, as well as respiratory infections. In higher income countries, the data really are only significant for reducing the rate of ear infections. For dental issues, there's sort of mixed data. In general, the finding is that there's a decreased rate of malocclusions among human milk-fed babies, but there's some data that if you continue to nurse while they have teeth after about a year and don't fully clean their teeth at night, that there may actually be an increased risk for cavities. For women, there's a benefit that when you're lactating, it can help with birth spacing. And there is also a reduced incidence of invasive breast cancers and a reduced incidence of ovarian cancer among lactating women. The obvious cost of human milk is the time and effort it takes to produce it. In this study of Australian moms, those who breastfed their 6-month-old babies exclusively spent 7 hours more per week on feeding them total, which is like a full workday, which is obviously a significant thing to consider. So now moving into physicians, let's talk a little bit about the baseline inequities for women in medicine, and then we'll talk about lactation barriers for physicians. So we know that gender inequity remains very present in medicine. There is an increased female representation in medicine, but not among leadership. There's a myth that women somehow do this to themselves by prioritizing other things, but we actually know that most women in medicine continue to face stereotypes, discouragement, and/or discrimination. In addition, we know that women are paid less for the same exact roles. If you take a man and woman in medicine, especially in an academic setting, who have the same title and same schedule over a 40-year career, you could expect to see a $2 million difference. And there's continues to be a significant difference in pay among leadership between male and female leaders as well. We know that physician mothers are one of the groups that has the highest rates of nursing initiation, but also are more likely not to meet their own goals. We know this from a series of studies where between 40 and 97% of female physicians reported that work obligations cause them to stop lactating early. One of the reasons is obviously just time and the total effort of being a physician. But another issue we know about is that lactation facilities are often insufficient in hospitals and clinics. Sometimes there is no space at all or insufficient space. Often there might be a lactation suite in a hospital, but not in all the satellite clinics, and it's too far away from where the person is working to be realistically used. Unfortunately, there are also high rates of rooms that are just not meeting minimal requirements, including hygiene requirements, or there's no workstation, so nothing can get done while the pumping is happening. And in one study, only 20% of 1,600 people had ever pumped in lactation rooms, but an equal number had had to use random unused rooms like patient rooms or bathrooms, locker rooms to pump, and a lot were pumping in their cars. So we know that this is also a significant issue, which we'll bring up in a little bit again. So what about psychiatrists? Are psychiatrists thinking about this issue? Well, according to PubMed, there are no papers focused on the experience of mental health professionals' lactation in the workplace at all. There are tons of papers about psychopharmaceuticals and lactation, and there are papers from a lot of other fields of medicine. We were able to find articles about barriers to lactation for surgeons, radiologists, anesthesiologists, pediatricians, internal medicine, and OB-GYN. So we wondered, well, why aren't we talking about this as a field? Well, maybe we're not talking about it because there's just an overall lack of data, so we don't know if this fits us or not, and it might be different. We do have very different practice models. But we theorize that psychodynamics and our feelings about boundaries also contribute to why this isn't always brought up in psychiatry. And I won't go through this entire list, but I think that we can easily see how producing milk as a parent can bring up feelings about competence, whether you're able to make enough milk for your child, masochism, so just feeling that there's actually something sort of morally right or good or feels right about doing something uncomfortable and difficult for the benefit of your child. Obviously, breasts can also be sexualized. And there's also this issue of how public lactation or even information about lactation should be. And there may be a sense of excitement or shame about feeding, pumping, or even storing your milk in a group fridge, for example. So we wanted to collect some data about psychiatrists and psychotherapists and lactation because there seemed not to be any. So we asked a bunch of basic demographics and questions about practice, the setting, where they work. And specifically, we really wanted to know whether the individuals responding had met their own lactation goals. We put together what we hoped was a comprehensive list of potential barriers and asked respondents to tell us which of these barriers they had encountered. And we also put comment boxes to ensure that since this is the first study of its kind in psychiatry and psychotherapy, that people could correct us if there were different barriers that they encountered that we had not considered. So this completely unreadable slide is just a little demonstration of our complex overlapped recruitment. We recruited in person via personal emails, via social media, and via professional listservs, including several ACLP listservs and the APA division for Society of Psychology of Women and some other listservs within our various hospital systems. 277 people accessed the survey, and of that, 235 confirmed that they themselves have lactated and answered enough of our questions to include them in the research results that I'm going to show you today. There are going to be additional analyses done in our multivariable analysis, which require that each individual specify that they either had or had not reached their goal in their most recent lactation experience. The reason someone might not have answered that question is they might still be lactating. And that will be included in the multivariable analysis, but there are 235 subjects included in the results I'm going to show you today. So we mostly surveyed physicians between 30 and 50 years old. The vast majority were partnered, white, and cis female. The work environment that most reported was being in the Northeast of the United States, in an urban environment, in an academic setting or an inpatient setting, and many worked in more than one field. And we have a pretty good array of fields, with the exception of forensic psychiatry, which for some reason we do not have any respondents in forensic psychiatry. As far as their parental and gestational experiences, most of the respondents had two children, most had had two lactation experiences, and most were the gestational parent as well. Of those who were able to report, 148 met their goal and 56 did not. So here's our chart of potential barriers. We categorize them as issues related to space and equipment, direct feeding or nursing barriers for individuals who are trying to nurse the baby directly at work, time and workflow barriers, barriers related to medical issues, pregnancy, or parental leave, and cultural and interpersonal barriers. So the most common by far that was reported were just not having enough time or workflow barriers, meaning that there would have been enough time, but their schedule isn't theirs to control and there was no time flexibility, and that was the barrier. Another significantly reported barrier was discomfort asking for permission for either time to pump or ability to pump during other activities, pressure against pumping, such as in meetings, medical barriers, and not having dedicated space or a place to store milk. As far as which of these barriers predicted not being able to meet the goal, most of the barriers that actually correlated with not meeting the goal were under the category of medical, pregnancy, and parental leave. So overall, that highly correlated with not meeting the goal. And then a lot of people reported leave was insufficient to establish a strong supply, and that they also had low or high supply or mastitis. So these are related issues because if your leave is very short, you might not be able to establish strong supply, which might then actually lead to having low supply or trouble controlling your supply or having an overdependence on an exact schedule for pumping. So those are related issues, but they both correlated with not meeting the goal. And the unrelated issue that correlated with not meeting the goal was not having access to a hospital grade pump, which we'll come back to as well. So just since these things are not in those charts, nobody responded that they were greater than 80 years old. We had nobody who was American Indian, Alaskan Native, Hawaiian, or Pacific Islander. We had no forensic psychiatrists. We had nobody who was currently working in Africa, Antarctica, or South America, and nobody identifying as trans. Otherwise, we had a fairly representative population that did relatively parallel the United States workforce. We found that degree type, being a physician versus PhD or all other types of psychotherapists, did not correlate with any particular barrier and did not correlate with whether the goal was met. Respondents who had more than one child were more likely to have faced cultural barriers. CL psychiatrists were less likely than other groups to have trouble accessing a lactation suite and several other types of medical and parental leave barriers. And we have a multivariable analysis currently with the statistician. And we also are in the process of doing a coded thematic analysis of the comments. So we hope to have additional results coming to you soon. So what can we say so far? So we know that lactation is important to physicians and also to psychiatrists and psychotherapists. And we know that the vast majority, I think we had 3 individuals who didn't encounter any barriers out of 235 that were included in this analysis. The most common issues are time and workflow or control over your time, and having short parental leave and medical issues that might be a consequence of short parental leave were the most likely issues to prevent reaching the goal. And the lack of access to a hospital grade pump was also significantly correlated with not meeting the goal, which we see as the most easily intervenable issue. Obviously, we also advocate for longer parental leave, but having hospital grade pumps is a much cheaper way to help people reach their lactation goals and to reduce the stress on these women returning to work than extending everybody's parental leave, which we recognize is a huge goal, but also could be hugely costly to hospital systems. As far as limitations, we cannot calculate a correct true response rate because of overlapping recruitments and because the listservs that we emailed had lots of individuals who have never lactated and would not be eligible for subjects. We also note that although we see that 1 year was the mode total duration response, we don't know how many of our subjects changed their goal at some point in the middle. So you might be saying, oh, my goal is 6 months, but then you're having a positive lactation experience and you extend it to 1 year or vice versa. So we don't know about that. We also only asked women to recall their most recent lactation experience. The reason for this is that we wanted to reduce memory bias because people will only, or recall bias because people will recall the most recent where they're not sure. But we recognize that we're potentially obscuring data, that there may be a learning curve between having 1 or 3 children. You may actually learn how to make lactation work better for you, or the opposite. You may realize that this is just not for you, and we don't have data about that. I want to point out, as far as this equipment issue that we found, that's a potentially modifiable barrier, that there is one little study where they created this really decked out suite where the personal pump, hospital pump, a private suite with a reservation that you could make, have as a computer, a telephone, dictation software, references, like everything you could possibly need to pump and do your work at the same time. It was only done with 6 residents, but it was done over 6 months, and they recorded all of the time that they spent. And they were able to increase their milk output while also saving 34 minutes per shift by having this correctly appointed suite. They also reported they missed less time from rounds. They were more able to monitor labs while pumping. They were able to get all of their work done. They were more comfortable. They were producing more milk, having an easier time. They were more relaxed, and they were leaking less. And this seems like a very affordable thing to do if someone wants to make a big difference, is creating a room that's completely private, that has one computer and a telephone and a $900 pump in it. This is a very achievable thing for a hospital system to add to help their workforce return to work and be able to be efficient while also achieving your lactation goals. So we think that it would be very helpful to create rooms like that, which is my point two here, that are sufficient in number, located near all the places people are working, and full of all the appropriate equipment, both for pumping and for multitasking. We think that this should be created with written policies allowing for maternity or other parental leave, written policies for lactation, so it's not left for individuals to advocate for themselves and beg other people to help them, and that these are triggered benefits, which are used to attract and retain excellent physicians, just like any other triggered benefits. People might complain that, oh, well, if you're lactating, you get to use these benefits, and that means they're not useful to everyone. Well, that's true, but most of us have life insurance that we're hoping we never have to use as well. But triggered benefits are still a good way to recruit and retain good people. This is also important to avoid burden shifting because we don't think it is reasonable to achieve gender equity simply by forcing someone's work onto a peer that happens to accept it in order to allow someone to have lactation time. This really needs to be done in a way that's thoughtful, logical, and documented in writing. And finally, we also advocate for allowing for effective, practical multitasking during meetings and during lectures, because it may be unrealistic to find completely separate time for lactation, and there shouldn't be cultural pressure not to lactate during a meeting. That's the best time to lactate, when you're speaking to your colleagues and it's not interfering with your patient care. We also want to remind everyone that lactation breaks need to correlate with human physiology, and that especially for those who are returning from a short parental leave, it may be necessary for that individual to specify when their lactation breaks happen, and for it not to just to happen when it's convenient for the clinical schedule, because that may be unrealistic or even impossible for some women. So specifically for CL psychiatry, we have thought about this a lot because our schedules do work very differently from a lot of other psychiatrists and psychotherapists. And we do think it could be reasonable to cap lactating employees a little bit lower than others, especially for the first 6 months or 12 months after returning to work. But there are a lot of other more creative ways that we can create flexibility in the schedule without necessarily just reducing the total amount of work. For example, someone coming back who is lactating might be absolved from having to attend behavioral codes where you have to respond immediately, because it just may be very difficult to be scheduling lactation time and also be available immediately. And we might be able to find other ways to allow for schedule flexibility. If you work in a hospital, clinic, or office where there isn't a hospital grade pump and there isn't a lactation suite, then we can also reassign shared office space to allow for privacy and efficiency during pumping breaks, so that work can get done and the person can pump in the office without having to waste time going to another campus or finding the lactation suite. So we think that those are some quick ways that we would think that might work for a CL service. I want to thank all of you for listening. I know that went by really fast. And I thank all of my collaborators on this presentation and on our multiple upcoming papers. If you're interested in getting a copy of one of those papers when all of our data are complete, please feel free to email me and I will send you those papers as soon as they are ready. And feel free to send me any other questions. Thank you so much for your attention and have a good day.